Hey everybody, I'm going to finish up, well, not finish up, I'm going to do the middle of the lecture on orthopedic surgery. So basically I wanted to separate the upper extremities from the lower extremities. So if you didn't see my post, the PowerPoint is next to your daily quiz today for the upper extremities, and tomorrow I'll have the lower extremities next to the daily quiz. I don't want to put it out today on purpose because it's so much material. I really want you to sit and read and study all of this stuff. So I know usually I try to get the lecture done on Tuesday. You know, if there's something left on Wednesday, we go over it, but it'll be a full lecture on Wednesday too, just because the chapter's so long. It's a lot of material. You guys have asked really good questions. Thank you. Keep them coming. And really funny comments too. I had two more, send me a message with their pronunciations of, actually they both did the same one. Sabra and Alexis did polymethyl methacrylate for me, and they both did a great job. So that put a smile on my face and lets me know you guys are listening. So stuff like that can always count as a comment and participating too. Lot of videos on YouTube, and there's so many more I could have put on there. One of the first things we're going to talk about today are total joints and how to prepare for those. So as you're going through, if you're ever confused on any of this stuff, just look it up. If it's not a question that you want to ask me, look it up. I guarantee you there's a picture of it or a YouTube video or something about it. So I posted about 60 videos by the time I was done on YouTube. So I don't want to do so much that it's overwhelming. So just think of that as you're reading through. If something pops in your head, just look it up and watch a YouTube video, or of course, ask me, send me a message. Before I get into the lecture, I've had a couple questions about what's going on in the world and how it's affecting scrub techs, so I wanted to address that before the lecture. So if you didn't know, the Surgeon General basically came out and said you're only going to be doing elective cases. This hits surgery really hard because most of our cases are elective. So that means only traumas coming in and people who are really sick, emergent cases are what's being done. So that means there's not a lot of surgeries for scrub techs to do. So what normally happens during these times, I say these times, this has never happened before. An example for me was like a tornado. When we got locked in, we had other jobs to do that had nothing to do with being a scrub tech. So I'm mentioning that so you can know that as a person who's going to be working at a hospital, you shouldn't expect to just do scrub tech duties. They can ask you to do anything, especially in situations like this. I know nothing like this has ever happened before, but natural disasters, situations where they just need bodies, it's going to be you. They're going to ask for your help. And I feel like that's our responsibility as healthcare workers to help out when asked. So just keep that in mind. My only example, of course, is during tornadoes. You get a code black, so you get locked inside the hospital, and they typically have you either work on the floor, checking on patients, transporting patients, or you're down in the ER helping as people come in and triaging patients. So you don't get a lot of training on that. It's kind of go with the flow, watch one, do one, teach one, as I always talk about. So just keep that in mind. In crazy situations like this, you could be asked to do anything, but hopefully that's why you signed up to do this, to help people. That's the whole point. So I don't have anything else to say about that, so I'll try to dive into this chapter. I love orthopedics. Hopefully you're seeing the coolness and the love of the power tools instead of the overwhelmingness of the instruments. So just think, you're going to be a student, you're going to be with somebody, they're going to help you through this. In addition to that, you're typically going to have a sales rep in the room if you have implants. So they're going to help you and give you step by step of what's going to happen next. So after you've gone through these things a few times, then you'll start to catch on to the patterns. Reading through these surgeries, you're not going to memorize these patterns, and I'll tell you which ones you need to know. The main one you've already learned in OMF. So drill, depth, tap, screw. That's the main thing you need to know for orthopedic surgery. So I will go over that again, but let's go ahead and dive into these procedures. So I stopped on 9:12, so I'll start on 9:13, shoulder arthroscopy. I'm sorry, I gotta get a drink of water. Okay, so shoulder arthroscopy. So I want to separate something right off the bat because of some of the questions I've had. So Arthroscopy, so it has a scope. We're sticking a scope into the joint. Arthroplasty, we are replacing that joint. We're doing a surgical repair of the joint. So when it says shoulder arthroplasty, knee arthroplasty, hip arthroplasty, that's a total joint. You're going to be wearing the hood, and you're going to be replacing that joint, repairing that joint. Arthroscopy, again, one more time, it's got a scope in it. So we're doing the opposite, very minimally invasive, making a small incision and sticking a camera in there to do the repair. So I just wanted to point that out from the very beginning so we don't have any confusion on these cases. And I'm going to pull up my PowerPoint so I can look at it as I go through the lesson with you guys. Okay. So top of page 913. So you really need to know the shoulder anatomy. So definitely review over the anatomy. You really need to understand how the clavicle articulates with your scapula. So make sure you understand the shoulder girdle and how that whole process works. I put lots of pictures for you on that anatomy review. But if you need more, let me know. Look something up. There's a good one in your book at the bottom of 913, but you can't really see how it articulates. So as far as the word for word in your book, looking at that first bullet point, it talks about the clavicle and the scapula and how they work together. The second bullet point is where it gives you that answer. Articulates with the manubrium on your chest and the the scapula. So the clavicle and the scapula are going to be articulating. They're going to be touching. So make sure you're studying your shoulder girdle and you're paying attention mostly to the processes that are going to be used during the surgery, like the acromion process and the coracoid process on that scapula. You need to know both of those. Okay, so that brings me to the AC joints. So acromioclavicular joint. So your acromion and your clavicle. So make sure you understand that joint and how we're going to be seeing it during these shoulder scopes. So there's lots of different reasons to have a shoulder scope. A lot of times people have scar tissue or torn ligaments, tissues inside that shoulder and that needs to be repaired. But I want you to know the specifics. So if you look at page 914 at the bottom, it's actually your last bullet point on that page. Procedures that can be performed include removing loose bodies, like I said, like extra tissue, bursectomy, so that's removing the bursa, that protective pad, rotator cuff repairs, extremely common, especially for our baseball and softball players, labral tear repairs, same thing, repair of impingement syndrome. So if you read about this impingement syndrome, you think all these ligaments and tendons are being impinged in your shoulder and it causes lots of pain and reduces their range of motion. We need to be able to move our shoulder normally to live our lives. So that's very painful and very important for life to have that range of motion. So that's why we're doing these surgeries. So if you're looking at the slideshow that I posted, which hopefully you are, anytime you're thinking about arthroscopy, so you already know there's a scope. So I want you to think of, what do I need for this case? So you're going to need an arthroscope, you need a camera and a light cord, and you're going to need the irrigation tubing because it's not like the belly laparoscopic. We're not going to insufflate with CO2 or anything like that. There's nothing to insufflate, it wouldn't go anywhere. So we're going to fill that cavity with water. So it's kind of the same idea of cystoscopy. We're filling that bladder with water so that we can see the whole time with the scope. This is the same idea. So there's water constantly flowing through. That's why you'll see there's a big bag underneath the drape to catch all that water. Some people actually hook up a separate suction tubing to the bottom of that bag so it sucks away all the water throughout the case so you don't end up with soaked shoes, but that is very common on these cases. The water can overflow, so you'll see your surgeons and hopefully yourself, instead of just shoe covers, wearing the boots so they are completely impervious so the water can't get through onto your shoes. So yes, lots of water irrigation, lots of different tools that they can bring in to do these repairs. So all the repairs I just went through on 914. So there's separate slides in your slideshow for all of these. So there's one for rotator cuff repairs with, I only put 3 of the videos. There's so many different ways to repair those. So one of them is called a speed bridge that I put on there. You'll see that it comes in a little plastic container. So basically you set up your case with your shoulder instruments, your scope, your light cord, the irrigation tubing, the stuff we've talked about. These extra supplies, these links to the videos that I put, this is what your sales rep is going to be bringing in the room for you. So typically they're not going to open it until they're actually about to do that repair. They want to make sure that's what the surgeon wants. A lot of the times they have multiple options for them. So they may be trying to guess. They might be looking at the x-rays, MRIs, CTs, the images to decide how they want to do this repair, but there's lots of different options. The main one that's used is Arthrex for shoulders. So I put lots of videos on here for you, and some of them are just links to Arthrex sites so you can see their instrumentation, but you really need to look through those so you can understand the process. This isn't the type of thing where you're going to memorize the surgery. I want you to think, same 3 questions I always told you to focus on. What instruments do I need? What instrument pans? What specialty items? These are examples of specialty items, what the sales rep is bringing in the room. And then anything else you need for the case. But really it should be instrumentation and specialty items that you should be able to anticipate. And again, all this is going to be on your surgeon preference card. So I know it's a lot of stuff, but it'll all be in your surgeon's preference card. It'll just be a lot thicker than usual. So now that you know all the different reasons for doing a shoulder scope, hopefully you can understand all the different slides I have on here for you. So as you're going through these, look at the instruments that I posted. You can see again that they're different types of sheaths. So they're not those plastic disposable ones. They look just like your instruments. So they're going to be reused over and over again. So a good time to remind you that anything that has a lumen inside of it. So like these trocars are a good example. You have that intercannula inside. When you send that to SPD, it needs to be apart because that lumen needs to be sterilized properly, and they could miss that. So what I always watched out for on orthopedic cases is when I'm setting up, I'm looking through the instruments meticulously, making sure that they didn't make a mistake. I only saw this once, but on a total pan, I was shocked that one of the handles for the reamers had a big hunk of bone on it. It had gone all the way through the cleaning process and it had been sterilized. So yes, that piece of bone was sterile, which everyone in the room kept reminding me, but of course I got rid of that pan because that's the right thing to do, and I got a proper pan that didn't have a piece of bone in it that had been sterilized. So you really have to check out these instruments because we're doing a lot of drilling and sawing and orthopedics, and bone chips are flying, so they can get lodged inside the lumens of these instruments. And even on the less invasive cases like these shoulder scopes, you can get things inside these lumens, so you got to make sure there's nothing inside those instruments before you get started. I think that's all I have on the shoulder scope. Actually, I really want you to focus on what instrumentation do I need to do a shoulder arthroscopy. The only thing I think that's not on the Mayo stand in these pictures is an 18 gauge needle, and I say that it's a spinal needle, so it's a little bit longer. So John actually talked about that a little bit yesterday. On any of the scopes, so shoulders or knees, they're always going to have a needle so that they can poke through and look with the camera and see, is that where I want to be? So it's kind of like marking their incision a little bit. They can manipulate some tissue with that needle, but they typically don't. We've got lots of good instruments for that. So it's kind of like X marks the spot with the needle. So spinal needle, and then all of the instruments that I put on here for you. So you can see there's lots of different graspers and cutters to help them do these repairs, but definitely watch the video so you can understand shoulder scopes. Okay, I'm going to go to page 917 for our Bankart procedure. So Bankart procedure, that's pretty rare to see it open, at least in my experience. I've seen one open. They typically like to do that arthroscopic because we always want to do minimally invasive, right? Less damage to our patient is what we always try to do. So if they could do it laparoscopic, they will. But as far as your anatomy, you learn it on the open procedure. So Bankart procedure, make sure you know what the labrum is. You know that that's one of your shoulder procedures is a labral tear. So, you know, they can fix this open or laparoscopic, but if they're working on that labrum, it's usually a Bankart procedure. So as far as your anatomy to study, the shoulder joint still, but it's basically more detail. So that cuff of cartilage, the labrum, know what it does. It's providing extra cushion and stability to your shoulder. So without that cushion and stability, your shoulder isn't going to be the same and have the same range of motion. This Burkhart procedure is named because of the tear, actually. What can be confusing as you're reading is it will say lesion, Bankart lesion. This Bankart lesion is a tear, just so you do not get confused as you're reading it. So that's an avulsion or a tear of that cartilage, and it injures the anterior capsule and the labrum. So make sure you understand how your shoulder works, your glenoid and your labrum, and all of your anatomy that I posted already for you guys. Look at your last bullet point on 9:17. So you'll see this lesion can cause the patient to have recurrent shoulder dislocation. So it's not just chronic pain like a lot of these other shoulder issues like the impingement syndrome. This is even more painful because think about that chronic dislocation. That's very painful for patients. Maybe Colton will get on and talk about how his shoulder dislocates sometimes, so you can get more of a patient feel for that subject. But let's flip it over to page 918 so you can look at the instruments and equipment you need for this one. So it says Bankart instruments. I know at least where I worked, we had a open shoulder tray and then the regular arthroscopic shoulder tray. So it could be different depending on where you're working. Power drills go with the drill bits. I put a video of your power drive on the YouTube channel, and then also the first one we're going to go over is actually the small battery drive. Basically, there's a different size battery drive for every surgery. Where I worked, we had a total battery drive, so they were the biggest ones used for only total procedures, so it was easy. Small battery drive, only for hands and feet. Everything else got the large battery drive. Made it very simple for us, but basically they're all handheld drivers that do the same thing. It's going to have a wire driver, it's going to have a drill bit driver, it's going to have a reamer, it's got a saw tip, it's got all these different tips and couplers for you to trade out for your surgeon. So you can use that same drill throughout the case. So as you're reading this and you're looking at the supplies, when it says power drill, I want you to think, what size of power drill am I going to need? So if it's a total joint, total power drill. If it's small like a hand or a wrist, small power drill. Anything else is going to be large power drill. And you can look at the differences on those on the YouTube channel. And of course, you can always look at Synthes website. So I've talked about Arthrex before. They do a lot of shoulder stuff, a lot of orthopedic stuff, but Synthes does also. And they usually are the users of the power drives. So check out Synthes website to see all their different power drives. Actually, don't have anything else on the open. I'm not going to go through that procedure, the Bankart procedure. So look at page 920. That's where they're going to go over the arthroscopic version of your Bankart procedure. And I've got a good picture of that on your slideshow, and it shows how they're actually keeping that shoulder up. So there's lots of different ways to do this on shoulder surgery. There's different ways to position it, but most people have a shoulder positioner. So you can see that in the picture. It's basically holding on to the end of the hand and it's pulling so that the arm is out so that they can work on it. I've seen surgeons have drape out another Mayo stand and have us flip the arm over like this so they can work on the shoulder and manipulate the arm constantly. We put gel pads on this Mayo stand before we draped it out, so it was nice and padded for the patient. It was safe, but I'm just pointing out that there's so many different ways to do this. So yes, this is typically how they're going to position to do these cases, but all of these shoulder surgeries, they kind of have their specific ways of doing it. So there's always different options. So just keep that in mind. So like when it says shoulder holder, they could also use a Mayo stand like I just told you. So surgeon preference as usual. So I want to move past the Burkhart procedure and go to acromioplasty. So 922, it talks about acromioplasty open. So this one's a lot for impingement syndrome also. So candidates, look at that first bullet point. Candidates for acromioplasty are affected with impingement syndrome, and it slows down their range of motion and limits their shoulder movement completely. So know that impingement syndrome is going to cause them lots of pain, so that's why we're here to fix this pain for the patient. Looking at your pre-op stuff, it's all pretty much the same. So same positioning, same draping, everything like that. So let's kind of go through this procedure step by step so you can think, what instruments do I need in what order? So very beginning, they make the incision. Shoulder cases that always have multiple tin blades. So you got a skin knife and a deep knife and some extras, because you never know how many extra knives you're going to need in orthopedic surgery. So extra tin blades, I would add that to number 2 on the page. And then the retractors they usually use automatically are going to be Gelpi retractors on shoulders. So Gelpi retractors. So they're going to dissect part of that deltoid muscle off, but they are going to go back and sew that back together at the end. So where it says you need that needle tip bovie, that's because of that deltoid muscle. They're trying to preserve most of it and do very little damage. So they're going to basically resect that for a moment, move it out of the way to do the surgery. They're going to sew that deltoid back down. So they're going to remove that deltoid muscle, and then you can go all the way to number 6 on page 923. So at number 6, they're going to add Holman retractors. So I'm pointing this out because you need to know what a Holman retractor is and what it looks like. It gives you some alternates if they don't want to use a Holman retractor, like a malleable. A malleable is always a good substitute because you can put it into any shape you want it to be. So if you ever don't have the correct retractor, malleable is always a good way to go. But Holman is what they would like for this one to protect the rotator cuff and the humeral head. So just think about where we're at in your anatomy. So the humeral head, so the head of your humerus, and they have that Holman retractor wedged in between that to protect the whole rotator cuff. So you need to know your shoulder girdle and your entire rotator cuff anatomy for these. Okay, so after that, they get their retractors in there so they can proceed with the resection, the fun part. So number 7, the section of the acromion that projects out is going to be removed with a rongeur or an oscillating saw. So don't forget your saws. Hopefully you went over this on instrumentation already. This should be review. Oscillating, I'll try to do this on the video. Oscillating side to side, reciprocating back and forth. Oscillating side to side is what we're doing on this procedure. So you got to make sure you have your oscillating saw. If they don't use an oscillating saw, it gives you another option. So osteotome and a mallet. So you have 2 options. So if your battery dies, you can get that osteotome and mallet out, ready to go to get that tissue off of that so they can not have that pain anymore in their shoulder. I'm pointing this one out, number 7, for the procedural consideration, actually. It's not just talk about power tools. So anytime you're using these power tools, you need to irrigate. So it says every few seconds, the ST should place a few drops of irrigation fluid in the area being resected. If you get that asepto syringe and you just pulse that water through, you're hitting an oscillating saw. It's going like this. Water is going to fly everywhere. Saline is going to fly everywhere. So that's why it says to slightly drip that saline onto that bone. You should never see smoke coming off of that bone. That means you're burning the bone. You're not irrigating like you're supposed to do. I think you guys know this from watching surgical videos on Jomi with me. If the scrub tech wasn't irrigating, I'm looking at the screen going, irrigate, 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 because I want them to irrigate that bone to protect it. So I want you to feel the same way. I don't want to see smoke. I want you to irrigate as the surgeon instructs, but typically just little drops like that. So I wanted to go over that part for sure. You want to prevent that bone from overheating, and you want to keep that saw blade from overheating too also. Okay, so like I said, bone saw or rongeur to remove those pieces of bone. After that, there are going to be some jagged edges, so they're going to get a bone rasp and rasp that off. It's like a nail file and make a nice smooth edge. After that, it tells you how they're going to close up and do the dressings. So I want you to look at the complications at the bottom of the page. So complication that the surgeon most wants to avoid. That's what I want you to pay attention to. So loss of anterior deltoid function. So as I said, we're cutting that deltoid muscle, right? And we're having to sew it back down. So your axillary nerve is very close there because you know where your axillary region is in your armpit. So basically they could hurt the nerve during this case. So they want to avoid that at all costs, and that's one of the big complications. So loss of function produces a poor surgical outcome for, of course, the patient and the surgeon. So basically, sometimes they can't restore that function if they lose it. So this is very important to be careful on these cases for the surgeon and to look out for that nerve. Another complication that could happen is the biceps rupture. So one of the first things they're going to do in shoulder surgery is look for that biceps tendon. So because they're working so closely with it, they could rupture it. So that's another complication. SSI is a complication for every single surgery, so I'm not going to go over that one anymore. Okay, so that's your acromioplasty. So I'm just going to go over the open one because I went step by step because you can actually see the steps. So acromioplasty arthroscopic. So same thing, but through little 11-blade poke hole incision trying to do these things. So you're going to have a rep in the room bringing you some things to anchor it down because it's not open. So it's going to be done a little bit differently. Okay, let me look at your PowerPoint real quick. Okay, good. So for all of these, I have videos for all of these on acromioplasty. You'll see that some of these videos aren't just going to say acromioplasty. So typically if you have a shoulder injury, you might have more than just your acromion that has an issue. So the one that I posted, subacromial decompression and acromioplasty. It's still the same thing. I want you to be reading the acromioplasty in your book as you're watching these videos, but there's more. I just wanted to point that out so you're not searching in your book for that procedure. You'll see that a lot with orthopedics. You might see in your book orif of a radius. The YouTube video will say orif of a distal radius, and the next one will say of a volar fracture. You're like, I'm confused. It's all the same thing. We're working on the radius. So don't let the extras on these surgeries confuse you. We're just doing extra procedures with the ones that you're learning, which is very common with fractures. Okay, so acromioplasty is on there for you, and I'm going to switch to total shoulder. So I love totals. I love getting to wear the hood. It doesn't say hood really in your book, and that's what scrub techs and anybody in the OR is going to refer to it as. If you'd like to look at a picture and a demo, see how it works, Google Stryker Flight Hood, and that's F-L-Y-T-E, Stryker Flight Hood. I didn't post a picture on purpose because there's multiple different ways to put that hood on. So it's actually folded up to where after you just scrubbed your hands, it's sterile. You could grab it and put it on yourself, but you have to be very careful to not touch anything else as you're covering that hood over your head. The way I always did it, they didn't allow us to do that. We would scrub, have our battery pack on our hip, have our hood on, the fan setting ready to go, and then we would walk in and our circulator would hood us, and then we would gown and glove ourselves. And of course, we would put the hood on the surgeon and gown and glove them too. Most important thing to remember when you are an extern is to go get that battery pack. You've never used it before, so you might be confused on what to get, so definitely ask questions, but go get that hood and the battery pack. Make sure you have your pants tied very tightly. I've seen people put that battery pack on, and then by the end of the surgery, their pants are falling down because it's a little heavy. So make sure you tie that down tightly and have everything you need before you try to scrub into a total joint. As John said, some surgeons don't like students on total joints, period. They don't want to risk that chance of infection because, as I've said, osteomyelitis is not something that's easy to treat. It's nearly impossible to get rid of that infection inside the bone. So we want to avoid that at all costs. So if you ever get denied a room for a total, do not feel bad about that. It has nothing to do with you. It's just because you're a student. On the other hand, at St. Francis South, I had many students get into total surgeries. So they do allow students in there. You just have to prove yourself. So if you prove yourself maybe throughout the week doing orthopedics, you might have earned the right to scrub in on a total joint. So typically, they're not going to have you be the first scrub the first time. There's a lot of instrumentation. You'll see that on your setups that I put on here. I did not put these on here to overwhelm you. I wanted to show you what it's really going to look like and how many pans you're going to have. Because you guys are used to one pan, right? One little major tray and you count it. So think about the positive when you're looking at all these instruments. So I'm looking at my shoulder instrumentation. I got 5 pans on the table, and that's not all of them either. That's just some of the instrumentation. Do I have to count any of those? Nope. I don't have to do any counting of instrumentation in orthopedics. So plus side, you get to play with power tools, wear a space hood, and not count instruments. It's a pretty sweet deal to have all the extra stuff. So it's worth learning how to do orthopedics. It's really worth it because it's a cool specialty to work in, especially total joints. Okay, got off track. I'll get back to total joint 925. So for shoulder arthroplasties, so again, total shoulder, these are typically done for chronic pain and a lot of patients with arthritis or rheumatoid arthritis. So specifically glenohumeral arthritis. So make sure you know that term in your book. So again, top of your humerus is gonna, you need to know where everything articulates with your anatomy. I'm not gonna go through it one more time on this one. But for these patients, that arthritis is going to limit their function and their range of motion. So that's why they're here to get a total shoulder. I want you to know some of the complications down at the bottom of that first bullet point about pathology. So complications include narrowing of the joint space, so that can cause that impingement syndrome, osteophyte formation. If you don't remember what that is, they're like little bone spurs, and cysts. So basically, if you have cyst, bone spur, anything else in that joint space, it's going to be causing you pain, limit your range of motion, and your ability to move your shoulder. So that's why we're here for the arthroplasty. So middle of the page about pathology, a reminder for you again, shoulder arthroplasty is not just for arthritis, it could be for your traumatic injuries too. So lots of different reasons. For total shoulders, let's flip over and look at the equipment, instruments, and supplies that you're going to need. So pretty much all of these cases, basic orthopedic tray. When it says that, a lot of places specify and they break it down a little bit more. So for instance, 2 of the hospitals I worked at had a large bone and a small bone. If it was a large bone, like a femur or humerus, you know you needed the large bone set. If it was a small bone working on hands or wrist or a foot, then you know you have the small bone tray. So don't think it's always going to say basic orthopedic tray. Sometimes it'll break it down a little bit more, but you'll need a basic tray to work with. Then your shoulder instrumentation tray. So all your instrumentation, so if you're looking at your PowerPoint, all the separate trays that you have laid out on there, your rep is going to be bringing those in. So what you need to have before the rep gets in there are your basic instrumentation trays and your power drive, your total power drive for this one. So they're going to give you other things that you're going to need. So like on your bullet point, we talked about this one, extra pair of gloves for every team member, including the surgeon, drains for the end, cement. I've told you lots of extra 10 blades. So on the bullet point where it talks about some of these implants being in-house and some are being brought into the facility, that's on you. You have to communicate that stuff. Typically, it's on the surgeon preference card. So I knew if I was doing a total, I could look at that preference card and it will tell me the rep and his name, and sometimes they'll even have the phone number on there. So you can call the rep and say, hey, where are you? I'm ready to go. I'm setting up. Get in here. Typically, they're going to be there ready to go because they know the schedule too. But it's nice to have those things so you can contact your rep if you need to. So you need to know your facility. So you need to know if these implants are just in-house all the time or if you're waiting on the rep to bring it in. Typically, surgeons aren't going to do their total joints without the rep. So they're not going to start until they're there anyways. It talks about, under practical considerations, how there's many different systems. So this is what was difficult for me as a script tech. I learned the first system, DePuy. Very proud of myself. Ooh, I got DePuy down. You get the next surgeon who uses a totally different system, Synthes. And I had no idea what I was doing. The systems are very different. So you might be doing the same procedure, but the instrumentation is very different because that's the whole idea. It's a different company. They're trying a different way of doing something. That's why surgeons have their preferences. They may not like Stryker, but they love Synthes. So you need to know what your surgeon is working with, and so make sure that you have the correct system in place for them, or the correct system open for them. Keep looking under practical considerations. So middle section of the page, many surgeons require that the team replace their outer gloves for the draping. So we've talked about a long time ago, most common time for contamination to happen is during draping. So because that's the most common time, I've told you our orthopedic surgeons, they're a little paranoid because of osteomyelitis. So they want to drape and then take the outer glove off, put another glove on, and then proceed with the procedure. I've already told you, and it's the next sentence down, I've already told you that a lot of surgeons are going to do this for the implants. So they're going to do that same process right before they put in the implants. So let me explain that a little further. These implants are going to come in a package, in a package, in a package, in a package. So it's going to look like a box at first and got a plastic covering. You got to take the plastic off and everything. You give the packages to your nurse. They open you a package that's sterile, but it's also in a sterile package and in a sterile package. This is on purpose, of course, because these implants are very expensive and we don't want to waste them. So it basically gives you a whoopsie, a 1 on the contamination because you have an extra package. The other idea is that a lot of surgeons don't want the scrubs touching their implant. So I could keep that implant in that last sterile package and bring it up to the Mayo stand and just open it and present it to the surgeon and let them grab it themselves. As far as that goes, if you don't do it that way and you actually hand it to the surgeon, that's the most important part, is don't drop the implant, period. That should not happen. Obviously, accidents happen. We are human, but you definitely don't want to do that, not as a student. So they typically won't have you hand over the implant as a student anyways, but these are very expensive, so you want to be careful with them. If you guys want, you could ask John about the paperweight that's on his desk. It looks like an implant to me, but you'd have to ask him about that personally. So I'm going to move over to page 927. So it goes through the procedure. I want you to read through. I'm not going to go through it all. I'm going to skip to number 7. So it talks about removing those osteophytes again. So again, those are like bone spurs. So we're trimming away those bone spurs from the humeral head, so the top of the humerus. They're going to be moving the arm a lot. So basically they want to check that range of motion. So they're going to externally rotate that arm and check out the humeral head to see where the issue is so that they can fix it. If you look down at number 11, so the humeral shaft is going to be elevated using that blunt Homan. So again, know what your Homan retractor looks like. For shoulder surgery, you're going to be using it a lot. So then it starts with the good part. You're going to start reaming the canal. So basically we need to ream the canal so we have somewhere to put the implant. So everywhere where the bone marrow is, that's where we're going to ream that stuff out. So then now that's out and we can put that implant in its place. That's the whole purpose of reaming. So one more time, you're going to use that Homan retractor and then you're going to use the curette. So that's how they're going to identify that they're in the intramedullary canal, and they're going to use a curette to do that. So we're going to use the power drive to ream, so you get to use your power. The canal is going to be reamed. This is a larger size thing, so we're always going in sequential order. So you're not just going to have one reamer, you're going to go smallest to largest. So kind of like dilating, same idea. You're going to line them up smallest to largest, and your rep is going to help you with that. After you ream, you're going to be doing your trial. So it's a trial to see, is this the size prosthesis that we want, basically. So trial prostheses are inserted next. And then number 14 is what John already went over with you guys. So your options are going to be press fit. They're going to be ready to be pressed together and fit and stay. Or you're going to use cement to attach that implant to the bone. So I need you to know in your book, number 14, your option for press fit is usually going to be for younger patients because they have healthier bone, so that's more likely to be successful using the press fit, whereas older patients, we're not going to most likely have that success, so we're just going to skip to the cement. So polymethyl methacrylate, again, is going to be mixed up. As they are mixing that cement, that's when you're going to pulse lavage. So in the other two total surgeries in your book, it says pulse lavage. In this one, it does not. I will tell you what it says, bottom of 14. While the cement is being mixed, the surgeon will thoroughly irrigate the humeral canal. Correct. They're going to do this with the pulse lavage. It actually has that brush tip on the end so they can get all the way into that canal too. So think about what we're doing. We just did a lot of reaming and sawing, and there's bone chips and fragments everywhere. We need to get that cleaned out before you put a permanent implant in, especially if you're cementing it in there. It's going to be there forever. So you want to clean that out really well. So hopefully you added in pulse lavage to number 14. And then of course they're going to get that prosthesis, and I already told you about the process for that, so make sure you're communicating with your surgeon so you know whether they want you to touch that prosthesis or not. And of course don't drop it. Very important. Flip over to page 928. So last thing, like I said, they're going to do is check that range of motion. So once they get that implant in there, they're going to check the range of motion and make sure it's exactly what they want before they close up. They should wash out one more time before they close up, so you can offer them irrigation for that. Because of the area of the body that we're in that cavity, and we did so much work, we're going to need drains to get rid of some of that blood and fluid throughout the case. So that's your total shoulder. Make sure you watch videos on how to put on the hood. Like I said, there's multiple different ways. You can put it on yourself, or your circulator can put it on. They know that students don't usually get the chance to do that. We actually have some hoods in the lab, so I will try my best to make time to let us do that, but there's not enough for everyone to put on anyway. The idea is you want to know what you're going to see before you get in there so you're not shocked, so you can go with the flow a little bit better. So make sure to watch some videos about total joints for sure. Okay, let's move on. Page 928, external fixation of a Colles fracture. So external fixators. So first of all, they have the picture on 931 if you want to look at the picture. And I put a picture in our book for us. So before the slide on, where is it? On your Colles fracture, I added in a slide about positioning and equipment for arm and wrist procedures. So we talked about this a little bit in plastics because they do hand procedures, but you're going to need that hand or arm table. So that's usually going to be connected to the bed. Some of them have a little stand, so it's just kind of tucked under that padding in the bed, and the little stand sticks on the floor. The surgeon, it's still their preference, but they're typically going to want the mini C-arm because then they can sit down at that arm table and bring that mini C-arm over that arm table. So the bottom is underneath the arm table and the top is on top, so they can take their x-rays more conveniently that way. It typically comes with a foot pedal too, so you want to make sure that has a cover on it because it'll get bloody, and sometimes you will have the foot pedal. So hopefully you remember your directions, take a picture, and go live. So live fluoroscopy and taking an individual picture for them so they can make the right decisions as they go through this procedure. So if we're doing a fracture, we're going to be doing x-ray. So of course you need to have lead on to go with that mini C, and then the drape to put on that mini C arm. Typically the biggest thing with students, they'll go put their glasses on, they'll scrub their hands, get all ready and scrubbed in, the patient's in the room. I forgot to put my lead on. Then they have to go scrub out and put some lead on. They might miss the beginning of the case, and that doesn't look good. Typically, you won't even get credit for the whole case if you didn't count it in the beginning. So it won't even count as a procedure if you forget your lead. So I urge you to remember to, before every case, you can ask questions, especially in the very beginning. Say, oh, it looks like we're doing a fracture. I need lead, correct? I'm going to go get it. Can you show me where it's at? So make sure you're getting your lead before these procedures and getting everything ready with the circulator in the room. There's a lot of equipment and different things that the circulator is going to need for these ortho procedures. I got off track again. Let's go back to Colles fracture. So as you're looking at your anatomy, you should definitely study this, but it should be a lot easier for you because I already went over all the hand anatomy. So you should really just be studying the tips of that radius and the ulna and see how it articulates with the wrist and where it articulates, especially the end of that distal radius. So this Colles fracture typically happens because we fall down and we catch ourselves. So that's our human reaction, right? You fall down, you put your wrist down to catch yourself. Can't do this in the video, and it bends backwards and you're basically breaking your wrist. So you can do a plate and screw for this, but they like to do the external fixator for this one also. So that's why the first one they went over is your external fixator. So in your book, bottom of 928, Colles fracture is an angulated fracture of the distal radius at the epiphysis approximately 1 inch from the wrist joint. So you're breaking the tip of that radius right above that wrist, so it looks like a broken wrist, basically. So you fell down, tried to catch yourself, and now you have a Colles fracture. So for these, look at the equipment and instrument supplies you need. I already went over most of it. It says C-arm in your book, so just keep that in mind. It could be the mini C-arm, as I said. As far as all these wires go, it says K-wires, Steinman pins, all that stuff. So remember the power drive I talked to you about. So we're doing a hand and arm cases, so small power drive. So you can watch that YouTube video about the small power drive, and I put it at the end of your slideshow. So small power drive, and I've labeled just a couple of the tips so you don't get overwhelmed with all of them. So you can see some of the tips you put a drill bit on, and some are for the wire driver. So typically that's one of the first things you're going to use on orthopedic fractures. So you're going to want that wire driver first to reduce the fracture, line it up, and stick a wire through it. So when it says wire driver, that's just part of your small battery drive. So as you're reading this stuff, if it says battery drive, it's everything. It's got the tip for your reamer, drill bit, saws, wire driver, anything else that you can think of. So again, K-wires for these, and then of course the external fixation device. So this is going to be a separate set that they're going to bring you, and you can see what that looks like on page 931. So I'll kind of go through this procedure. This is our first ortho hand procedure. So after they make the incision, hopefully you should know this by now, first thing they're going to do is scrape that periosteum off of the bone. So use a periosteal elevator. They typically use key elevators, small key elevators on arm and hand cases. After that point, the periosteum's off, so they can go ahead and drill through the bone. I've gone through the patterns with you guys, but I've left out little things like drill guides because you're going to see these in the sets. So this one talks about grabbing the correct drill guide that coordinates with the drill bit. So this will come with practice as you use them, but that always made things simpler for me, because if you open a big tray and there's a million screws and a million drill bits, it's a little overwhelming. But think there's only two that match together. So I'm going to match that drill bit and that drill guide together and hand them the correct one to start this procedure. So they're going to use the drill guide as they drill, and they're going to put in those pins. So as I said, they might call it a drill, but it's a wire driver to put those pins in. They're going to do this under fluoroscopy, so that's down at the bottom, number 7. So they're going to confirm the placement of the pins and reduce that fracture. So they get those pins where they want them through the bone. The pin is still sticking out of the arm. Now they can add the external fixator. So I like these because I got to do a lot of hands-on putting on the external fixator, especially if it was on, say, a leg and it's very long. They need help putting all these extra mechanisms together. So looking at 931, number 9, clamps or joints are slipped over the pins and longitudinal supportive rods are put into place. So this is the part that you get to help with sometimes, because they've already done the invasive part. They've drilled a pin through the bone, and now it's sticking out of the bone. We're just adding the external fixator on the outside of it. So you get to use some wrenches and some other tools to put this external fixator together. So if you like working with tools, you will definitely like putting on X-fixes, is what they're going to call them, but external fixators. So there's all types of different sizes. This is the smallest one you're going to see, this Colles fractures external fixator. So there's a picture on the slideshow for you and in the book on that one. Okay, that brings me to orif of a radius. This will pretty much be our last procedure also. So let me get a drink of water. Okay, so orif, I want to go through the order when we get to it again. So that drill, depth, tap, screw. I want to go into a little more detail on that. But let's go, beginning of the procedure. So you broke your radius. What do you need to fix this? Same thing you needed for the Colles fracture, right? Hand table, tourniquet. The only thing that's different is we're going to use a small frag tray. So you just saw external fixation. So we just drilled through the bone. We didn't make big incisions, anything like that. ORIF, open reduction, internal fixation. So we're making an incision, we're opening. Then we're going to reduce it, and when it says internal fixation, that means a plate and a screw internally. So hopefully, now that you've seen these two procedures, you can easily understand the difference between external fixator, which means pins in the bone, but the fixator's outside, and then internal fixation, which is a plate and screw on the inside on your physical bone. Then there's nothing on the outside. We're just going to close it up and probably splint up your arm. So make sure you understand the difference between open reduction, internal fixation, and external fixation. If you don't understand that for some reason, please send me a message. You need to understand the difference between the two so you know what you're doing on these cases. Okay, so hand table, as I said, and then small frag tray is what's going to be different on this one. So you can look at Arthrex version of their small frag tray or Synthes. There's lots of different brands, but basically there's a frag tray for every different size bone. So small, mini, small, and large frag. The mini frag's typically done for hands. So let's start from the beginning on this one. So go down to surgical procedure. So the incision on all these orthopedic procedures, unless it's a total, I'm going to say incision based on fracture, because that's what it's going to be. You're not going to always know exactly where the incision is or have a special name for it. Incision based on where the fracture is. So after incision, you already know, scrape off that periosteum. So number 3, key periosteal elevator. After that, they get a curette to remove that blood clot that's usually there from the fracture. Sometimes they're just seeing what the edges of those bones look like too, to see if they're sharp. But they're going to curette out any extra tissue, and the blood clot is removed if it's still there. Number 5, they're going to put on bone clamps. So I told you about these bone reduction clamps yesterday. Some of them are called bone reduction forceps, but they're all going to basically do the same thing. On this one, I would make a note, because I always use the same reduction clamps on radius fractures, and it was always the ones that looked like the little lobster claws. So they have a specific name in your orange book, but the ones that look like the little lobster claws are typically going to be used on these. But bone reduction forceps are going to be needed for these. So that's what it means when it says bone clamps on there. So after they get the bone clamps on, they want to try to reduce this fracture, and then they're going to fixate it with a K-wire. So K-wire, again, you're going to need that wire driver. So look at your small battery drive on your slideshow, and you'll see that there's a wire driver attachment for that. So you're going to start with fixating that bone and putting in a wire. Now it says you can fixate it with a screw too. You can do that, but I'm trying to give you the normal routine that we typically do for these orthopedic surgeries. So typically they're going to do that wire first instead of a screw. So wire to reduce that fracture. Number 6, the surgeon's going to request the plate. So typically just by looking at it, they're going to know, this is what I want, I think. So they'll ask you for, let's say, a 5-hole plate. So you find a 5-hole plate and you hand it over. Now all of these are labeled right and left. So it's important, the laterality is very important because you're working on the distal radius. That's very specific anatomy. And you can look at those plates on the slideshow too. It's specific, made to fit the tip of that radius. So it doesn't look like a lot of other plates. After they request the plate and they decide, yes, that's the size I want, from there they're going to start bending and forming that because they want it to be flush with that bone. So they're going to shape it to where it fits on that bone perfectly. So you'll have different plate benders inside your set, and you can bend those plates in the right way for the surgeon, or typically they're going to do it themselves. Okay, procedural consideration for that one. Plate must be contoured to fit the radius, as I already said. Let's look at best part, number 7. You should know this routine. If for some reason you don't, that's why I'm reviewing it, because it's very important. You should 100% know this pattern before going out to externship. So one more time, you're going to drill, you're going to check the depth with a depth gauge, you're going to tap, unless it's a self-tapping screw, and I'll get into that. You're going to tap, and then you're going to hand over the screw. So let's start at number 7. I'm going to read through it and go through this pattern. So the plate is placed on the bone, held in place with 3 or 4 bone holding forceps. We already know we have the drill and drill guide ready. They have that plate laying on there. They drill the first hole. So first hole is drilled, step 1, drill. Then sorry, I lost my spot. Using the drill and the drill guide, the first hole is drilled. Then it's tapped unless it's self-tapping screws. So I'll get into that. So tapping, you're basically cutting a thread into the hole. So you just made a hole. And when I went through this the first time, I should have gone over what tapping is. I just assumed, and I shouldn't have. So I'll go over exactly what that is. So they're tapping basically to cut a thread line through that hole. So that's why some screws don't need that. They're self-tapping. They're sharp on those edges and they're going to thread themselves through. So they don't need that tapping. So you need to know as you're getting these screws, make sure you're communicating and learning whether they want tapping screws or self-tapping screws. And that depends on whether you have that tap ready to go. So I'm going to go through this again, and we're tapping, so not self-tapping screws. So we laid the plate down, we drilled the hole, and then we tapped it because we're not using self-tapping screws. After that, you're going to hand over the depth gauge. They're going to check the depth. As they're using that depth gauge, I'm with my screwdriver next to the screw caddy waiting for the number, waiting patiently. The second they say that number, I get that screw, I double check it. There's a little line on your trays that basically have the calibration so that you can measure any screw. So on the tip of that screwdriver, you can lay it down. Yep, that's a size 12 like they asked for. When you hand it over, you need to say the size. So I don't care if they just said, I want a 12 millimeter screw, and you had it in your hand, and half a second later, you're gonna say, here's your 12 millimeter screw. So think of it just like medication. Even though it's very repetitive, it might even be annoying to repeat it that much, you're gonna repeat it because it's very important, because you don't wanna put the wrong size in there. Communication is key. So one more time, drill the hole, check the depth, tap, screw. So make sure you are, number one, measuring that screw, and you have to make sure you have the right screwdriver to go with it. A lot of these trays have multiple different screwdrivers, so it might say hexagonal screw. You need to know that that goes with the right screwdriver. So not gonna get a lot of Phillips and flathead in there. You need to know the different types of screw tips on the end. Okay, so that was number 7. I went through the order with you. Now let's talk about self-tapping screws. So self-tapping screws basically cut their own thread, like I said. So they tap their own thread is the term I want you to know. So after they tap their own thread, they don't need to be tapped. So that's why you can skip that section, basically. So basically step 3 tapping can be skipped if you have self-tapping screws. Okay, procedural consideration. It kind of goes through it again with more details. So I want to go through it again. So same sequence. It says the quick coupling device should be loaded on the power drill. The coupling device is one of the tips that goes on your small power drive on your power point that's on there. So I didn't label that one. I just labeled your wire driver, but basically that coupling device, you can put different things on the end like a drill bit. So quick coupling device, it's talking about your tip on the end of your hand drill to where you're ready for drill bits. So quick coupling device for drill bits. Make sure you have the correct size drill bit. After that, the correct drill guide to go with it. When the surgeon's using the depth gauge, you can go ahead and hand over that tap, and then the surgeon will communicate the size of the screw needed. And then I've already told you that part to make sure you measure before you hand it over. After that, you can look at number 9. So they're going to irrigate out the wound before putting on their dressings to close it up. So I like fractures because once you're done, it's like you're done. It's not a big abdominal procedure where it's going to be another 30 minutes of closing, especially if it's like a hand or arm procedure. As soon as you're done, irrigate, we're going to be done and out of there very quickly. Sometimes the longest part of orthopedic procedures is putting on the splint at the end of the case. So I went over those materials and things that you need, but as you're reading through these upper extremity procedures, look at what they're going to do after the case post-op, whether they're going to get a splint or a sling or something like that before they leave the hospital. So I'm going to start at 9:34 ORIF of a hip tomorrow, and I will put a slideshow for that on on MCC also. I think I better stop talking because I'm getting all tongue-tied. So if you guys have any questions about upper extremity orthopedic surgery, please send me a message, ask me a question. If there's not enough videos, not enough pictures, something, let me know. I can help you out. So Tell me if you need anything. Talk to you guys soon. Bye.